Hi, this is Doug Rex. I'm professor of medicine at Indiana University School of Medicine, and I want to tell you a little bit about a study that we just had published in gastrointestinal endoscopy, and I'm going to read the title of the study. It's called SIC 8000 versus Hetastarch as a submucosal injection fluid for endoscopic mucosal resection, a randomized controlled trial, and this was just published online in the last couple of weeks. So the importance of the study has to do with the fact that we don't have that much in the way of randomized controlled trials about what submucosal injection fluid is best for EMR, for endoscopic mucosal resection. And the general thought, I think, is that it's better to use a viscous solution. A viscous solution tends to form a mound that is more concentrated, perhaps doesn't spread out as much, and then persists longer compared to saline, which, as we all know, tends to diffuse out fairly rapidly. So earlier, we had participated in a randomized controlled trial of this compound SIC 8000, which is marketed in the US as Eleview and is the first agent to be approved by the FDA for submucosal injection. It's actually approved as a device. And it's interesting that ORISE, which is the second material that has been approved, really was approved with SIC 8000 as the predicate device. It doesn't have an independent randomized controlled trial. So this first randomized controlled trial with Eleview showed that it was superior to saline. You could remove polyps in fewer pieces. There was less piecemealing. And we often measure that by what's called the Sidney resection quotient, which is basically the diameter of the lesion divided by the number of pieces that you remove it in. So the higher the Sidney resection quotient, the better. This is one of the measures that Michael Burke's group developed for measuring sort of the quality of the fluid. So Eleview had been superior to saline. Well, the downsides of Eleview are, first of all, that it's expensive, and I guess that's actually the main downside is the cost of the material. And for a long time we have used Hetastarch. Now, Hetastarch you can buy either as generic Hetastarch, or it's available in some specific products like Voluvin or Hespan. It's all pretty much the same material. It is more viscous than saline, but there's very little controlled data about it. For us, it's less expensive because we are allowed to get a 500 ml bag of it in the morning and put it in a particular place, not in the room, and add some contrast to it. We usually add indigo carmine, and then, at least for that day, we're allowed to draw it up and take aliquots of it into a procedure room, and we can use one bag for the entire day. Some pharmacies won't allow that to happen, but it makes it quite inexpensive, even though indigo carmine and methylene blue, the two contrast agents that we use, have been expensive for some time to buy them independently. So we were interested in how that usual Hetastarch compared to this new product, Eleview. So we set up a randomized controlled trial. I decided to target adenomas and to exclude serrated lesions, and the reason is that I kind of think serrated lesions are very easy to lift no matter what you put under them. So they do quite well with saline. They have very little submucosal fibrosis, and they tend to form a very nice mound even with saline. Adenomas have a bit more submucosal fibrosis on average. Just in general, it's often the lesion that determines the quality of the mound. But I wanted to do the study in adenomas for that reason, and we chose lesions that were at least 15 millimeters in size as measured by the snare, and then we used some standard endpoints like the Sidney resection quotient and the volume of fluid that was required to get a good mound. And we blinded the study by taking the Hetastarch and adding methylene blue to it, because that's the contrast agent that is in the Eleview also. So the two fluids looked very much alike, and also the technician who was injecting it was blinded as to what was being injected. Well, it turned out the Sydney resection quotient was higher with Eleview. So Eleview did, for the primary endpoint, turn out to be better than Hetastarch. It wasn't a huge difference. It was a little over 9 versus a little bit over 8, but it was statistically significant. And then one of the secondary endpoints, which was the volume of fluid that was injected, was lower at about 14.8 mLs versus a little bit over 20 mLs with Hetastarch. So by a couple of the important endpoints, these are actually pretty similar to the endpoints by which Eleview had been superior to saline in the original study. So I think you'd have to conclude based on our study, and sort of expect this is an investigator-initiated study. It was not sponsored by a pharmaceutical company, but almost certainly you're going to get these investigator-initiated studies. It has some limitations in that it was performed at a single center. I was the endoscopist for all of the study procedures, so that could suggest some limited generalizability, but nevertheless the results suggest that Eleview is superior to Hetastarch as a submucosal injection agent. Obviously it'd be nice to see other groups do that. Now the differences are not huge in terms of either the Sydney resection quotient or the volume of fluid injected. So I think depending on what it costs you to buy indigo carmine or methylene blue and to buy Hetastarch and how you use it, you might need to kind of weigh these differences that were observed in the superiority of Eleview versus how much extra it's going to cost. And I think those are the things that would sort of go into the equation. And I think we should hope for other investigators looking at these and other fluids that are available now to try to get as much information as we can about what the best submucosal injection fluids are for EMR and also, of course, for ESD. So thank you.